Hi, I'm Dr. Sadie Larson, clinical psychologist and member of the ISTSS Public Information and Education Committee. One of the goals of ISTSS is to disseminate high quality knowledge and education to enhance quality care for people with PTSD. And as part of that goal, the ISTSS Education Committee is collaborating with people who developed or implemented the interventions that were highlighted in the ISTSS Adult Prevention and Treatment Guidelines. So today I'd like to welcome Dr. Anke Ehlers. With a team of collaborators, she developed cognitive therapy for PTSD, which was identified as a psychological treatment intervention with a strong recommendation in those clinical practice guidelines. So Dr. Ehlers, thank you so much for joining us today.
My pleasure. Thank you for inviting me.
Yeah, well, why don't you just start with the kind of overview? What are the specific goals and the key components of this intervention?
Yes, so cognitive therapy for PTSD is one of the evidence-based trauma-focused CBT programs developed specifically for PTSD. And it has basically our research identified three components that are essential to target in treatment through both experimental studies and also prospective studies showing us what maintains PTSD, what keeps it going, because many people recover on their own even after horrific events such as traumas. And these are, first of all, we identified specific characteristics of trauma memories and also of their triggers that lead to the re-experiencing symptoms, which are so central to PTSD. And I mean here the wide range of re-experiencing symptoms, not only brief intrusive memories of the event, but also like the bodily sensation, the emotions that can sometimes occur without the person actually making the connection with trauma at the time, and the extreme end then dissociative reactions to trauma reminders. And the goal is to change these characteristic that leads to the re-experiencing. And with that, I mean, we identified that the trauma memories are quite disjointed. So different moments in memory don't hang together. So when the person remembers or is triggered to remember their worst moments, they come back with this here and now quality and an overwhelming quality. And the patient actually at that moment can't actually access other things that they have in their memory that tells them that the trauma is over, for instance, that they survived the event. It's really like at the moment they will re-experience the threat to life they experienced at the time. And so this is one of the targets of treatment, but then closely connected to particular moments in memory, we have different individual meanings of trauma. So we've in our studies and treatment, we have seen so many people who were even in the same trauma and come out of it with completely different meanings. And this to realize how individual the meanings are that people take away from traumas is essential, I think, for understanding PTSD. Those who develop PTSD and don't recover from PTSD have enduring, very threatening meanings that either are threatening to their sense of self, so that maybe they think they are to blame for the trauma, or more generalized thoughts such as I'm inadequate, I'm a bad person, so very general negative view of herself that develops in the aftermath of trauma. Or the threat can be more external about the other people, I cannot trust anybody, or the world in general, that the next trauma is going to happen, or there's no justice in the world. And again, these can be very specific to the trauma, but also much more generalized, especially if we consider people who now, in at least here in the UK, would get the diagnosis of complex PTSD according to the new ICD-11 classification. So these individual threatening meanings are very important to change. And along with the threatening meanings, there's also coping attempts that people have. They have strategies to try to deal with the threat they are perceiving, which comes from both the re-experiencing these memories in the here and now and the individual meanings. And they make a lot of sense from the patient's point perspective, but they unfortunately maintain the PTSD symptoms in various ways. For instance, they inhibit a changes in memory and also in the meanings that people are taking from the trauma. So they can't take a new information that would correct these meanings. And so these are the three targets. And I think they overlap with some of the targets in other trauma-focused CBT programs, but we have a specific approach. And the first characteristic is that we are using a very individual case formulation. So for every patient, we really look at the memories, the meanings they have, and the specific coping attempts they're making to come up with a very individual case formulation. And that guides the treatment, it guides exactly the interventions that we are doing, and also the order in which the interventions are delivered. The core interventions then are, first of all, from the very first session onwards, we work with the patient on reclaiming parts of a life that they haven't lost, but they had kind of dropped out of their repertoire through social contacts, important activities in their life, work if they have stopped working, or rebuilding their life. So for people with very early traumas, or let's say war-related traumas where they lost a lot of their lives, there it would be more a discussion about how can we build a new life for you that is meaningful and enjoyable. And we start that very early on to give people hope, but also really to counteract a very common meaning of trauma to people's lives, namely that the trauma has destroyed my life. I have completely changed as a person. It's irreversible. And by rebuilding a life, we can counteract these meanings. The other interventions then focus on the meanings and the memory features, and we do it in a very integrated way in the procedure that we call updating trauma memories. We look for the worst moments in trauma that come back in re-experiencing, both through talking with patients about what their personal re-experiencing symptoms are, but also by going in quite a lot of detail through the trauma, either by writing a detailed narrative or doing some imaginary reliving in a very focused way, though it's not repetition of going through this, but just like to identify what are the moments that we need to work on and what are the meanings. And then we use a range of cognitive therapy techniques, and they depend on the type of meaning to help the patient see these moments in a new light, see disconfirmation of some of the threatening meanings. So maybe the fact that you didn't fight back doesn't reflect badly on you. That was the best you could do at the moment. It was the perpetrator's fault, not your own fault, for instance. So we're looking for information that we can generate together, both in this discussion with the therapist, but also often in more experiential exercises that we're doing with them to give them new learning experience, such as behavioral experiments. And then we don't stop there. We then, in the third step, once we have a convincing evidence that can show them that they haven't died, that it wasn't their fault, and so on, whatever their individual meaning was, we then really explicitly link with what they learned in therapy to these very worst moments in the memory. And that's a very specific work. And we found that the third step is really important to really give the full emotional change in the meaning as well, not only like a rational insight, oh, it wasn't my fault, but really demonstrating to yourself, it wasn't your fault. You are not a bad person. So that's very, very important in our view, to especially more complex trauma or complex PTSD, really getting this emotional shift in the meanings as well. And then we also work on the triggers. Patients come to treatment often with, they know some triggers, but then they also report that there's lots of re-experience they have without knowing what the trigger was. And we work with them on identifying the very specific sensory elements of situations that they may not be aware of, and they don't have any connection usually with the trauma. They just happened to be associated with the trauma. And to identify those kinds of triggers, it could be a certain pitch of sound, it could be a color, it could be smell, it could be a certain touch, like body part being touched or something like that, a movement. So very often very sensory, very specific sensory cues that we can identify. And once we have identified them, we can work with the person to discriminate the original cue in the trauma. Let's say the perpetrator's hand was coming towards me before he hit me, from the current situation. Let's say it was my child who wanted to give me a hug, and really see what is the similarity, which is only like one aspect. Something was coming in my direction, a movement in my direction, and everything else in the situation is different. And patients can practice that and then in the session, but then also apply this technique in everyday life to reduce the re-experiencing further. And finally, then with the last component of our individual formulation, the unhelpful coping strategies. Again, very individual what people do, but it's always meaningfully linked with the meanings they have. So if somebody thinks it was my fault and blames themselves for not fighting back, they might ruminate a lot about it. A very common pattern in PTSD, and we work with them and to identify that rumination is actually not helpful. It actually may trigger more intrusive memories, and they learn to interrupt themselves when they start ruminating and move on to other things. It's excessive precautions for other people. They can be very extreme, so that people become more or less housebound, and we work on that with them. And it can be also strategies to numb your emotions, such as using drugs or alcohol to numb emotions. So very individual pattern, but again, the same principle. We will work with patients to really find out that these strategies make sense to them at the moment, but actually they are not helpful in the long term because we keep the PTSD going.
So there are certain kind of mechanisms that you're looking at with every person that you're with, but it
Yes.
sounds like what the treatment would actually look like could be quite different from patient to patient.
Yes, that's right. And it really depends a lot on the individual meanings and also the personal triggers and the content of their intrusive memories. But it has the same underlying principles, like we call these 3 factors, like the treatment processes that we also then monitor in treatment. And our research has also shown that monitoring these processes, like the memory features, the meanings of a trauma, or we call them appraisals in the cognitive therapy language, but meanings is probably a more understandable word, and then the unhelpful coping strategies. If we monitor them in treatment, we actually can see that if we have weekly treatment, from week to week, the changes of these processes predict actually the symptom change. So that's quite good evidence that this is kind of a driver of the symptom change, so that we are on the right track when we work on these processes.
Yeah, I mean, that actually gets into one of my other questions, which is just about kind of how you measure progress in treatment. So it sounds like that goes a little bit beyond, you're not only measuring PTSD symptoms. So can you talk a little bit about what
Yeah, I
clinicians
think
are tracking?
that's right. Obviously we would monitor the PTSD symptoms. We usually also monitor other symptoms such as depression and anxiety symptoms to see sometimes, for instance, there is a bit of a lack of the depressive symptoms when we're already seeing changes in the PTSD symptoms. and that could be due to then their life still being quite restricted. So we have to work more on the rebuilding your life. And then quality of life, I think, is an important one to consider. So there's various measures of that, but just like how much can they go back to a meaningful life, and there are some quality of life questionnaires. But then we also routinely do weekly measures of these process measures where we have questionnaires for the meanings, the
Mhm.
behaviors, and the memory features. And that can help the therapist also guide the interventions, because the therapist may think, oh, we had this good session and there was quite a lot of change in meanings or beliefs in the session, but then they see on the questionnaire when the patient comes back, it actually hasn't really changed. So there was something that the patient wasn't fully convinced by your intervention. So we find it incredibly useful to use the process measures as well.
Mhm. Okay, yeah, that makes a lot of sense. Can you talk a little bit about the kind of population that you would think of this being useful for, and maybe how that's changed or expanded over time?
Yeah, thank you. Yes, so it was from the beginning designed to be a treatment that can be applied to any kind of trauma that people have reported. Interpersonal traumas are probably the most common ones. So in our studies, we had quite a few people always who had interpersonal traumas, but we also had people who had experienced severe accidents or who had lost somebody in traumatic circumstances. So these were the main, um, yeah, in our first studies we concentrated on those. But we were also looking at some people who had quite extreme traumas, such as political prisoners who were tortured, for instance. So the aim was always like to find out what's the commonality of what keeps the PTSD going in all these different populations. But at the treatment studies, we had, I think the interpersonal traumas were the vast minority, then accidents, and then traumatic loss of a loved one. But then also people who encounter traumatic events as part of their profession. So that could be either in combat for soldiers, but also like paramedics, doctors, and nurses, and so on, care professionals who had traumatic experience, either being attacked at work or witnessing horrific death of other people was quite common.
Mhm. Yeah, and it seems too that I've seen some of your work that's looked at different moral injury or looking at this during the COVID-19 pandemic
Yes,
or
yeah,
with different racial or ethnic populations. So there are a lot of ways that it can
yeah.
be tailored to kind of different groups, different
Yeah, I think
presentations.
that is the advantage of the individual case formulation. You can go with whatever the person's beliefs are, and that can include cultural beliefs. So when we worked in South London, that's an ethnically very diverse catchment area, we had people from all kinds of backgrounds and including different religions and so on. And so we learned a lot from our patients, and obviously they are the expert in their cultural beliefs. We don't know that, so we learned from them. And as you said, in the pandemic, that was especially came prominent as well, because people lost their loved ones under these horrific circumstances where they couldn't be there for them, and funerals were not couldn't follow the usual procedures. And we learned how different yeah, the beliefs about afterlife, or the beliefs about what a good death is, and or a good uh, funeral differ a lot between people with different backgrounds. But there's always a common in PTSD, there's always the common theme. There is something that didn't go right and that violated their beliefs, and we can work on what they personally then found so horrific about what happened. beyond what everybody would feel in the situation, like the horrific death of a loved one under these circumstances. But there were these specific additional meanings for them that kept the PTSD going that we could then work with.
So if somebody was wanting to implement this intervention, what resources or training do you think are required to be able to get started?
Yeah, to get started, I think attending some workshops would be a good starting point. And we have had our group is not very big, and we can't give workshops everywhere in the world. So that's why we created our Oxford Resources website, where clinicians can register free of charge. And we have over the years put together quite a lot of workshop materials, like videos on specific parts of the treatment, and also treatment materials that we use. And if you register as a clinician, you can access all these materials for free. It doesn't cost anything. So that, I think, would be a good start. We also hear from people who've used the website that it's kind of a big memory load to remember everything about the treatment you want to do, and especially if it's about some work that's quite hard to do, hearing about people's traumatic experience. And so we have also heard that people then also come back to their website if they have to prepare for a session if they are preparing for a session with a particular patient and want to refresh their knowledge of how do we do a pie chart technique, for instance. So the videos are relatively short, so that can be also a bit of a refresher then, or in a presentation you haven't come across yet, so it's a mixture of videos on the specific techniques, but also then on specific problems, like there's one on how to work with refugees, for instance, which complements the others and draws on the other videos as well, but it gives a few more tips about the specific population.
Yeah. Okay. So a lot of resources. I've looked at the website. It's amazing. It's a great resource. And what challenges and lessons have you learned from implementing this intervention now for many years,
Yeah.
or advice for agencies or clinicians thinking about implementing it?
Yeah, so I think from kind of service perspective, we've encountered some obstacles sometimes due to the limited resources we have in the National Health Service. So some services have arbitrary limits of the number of sessions. It's the treatment is very focused, so it's meant to be. It's not designed as a short-term treatment, but some of the limits that have been set in our experience were too low. I think there were early studies showing that PTSD can be treated in 8 sessions, and then 8 sessions is not enough for the average patient in our experience. It's so we have usually recommend that if somebody has, like, the main traumas that you need to work on is a limited number, or like similar incidents and over a longer course of time, like such domestic violence, then we would recommend offering at least 12 sessions. And in complex PTSD or multiple events that have to be worked on, then we would recommend more sessions. And I think services need to acknowledge that it's a tough disorder for the patient and also for a therapist to treat, so not arbitrary. And then the other experience is that it is really hard to just learn the treatment by watching videos or coming to a workshop, and that supervision is, especially if you're new to the treatment, supervision is really extremely helpful. So we run a course for NHS England here for therapists who have gone through basic training in CBT, but then want to specialize more on PTSD. And there we have scheduled supervision groups and the whole training and and a series of workshops. And there the whole training takes then about 6 months. And the feedback is that people learn so much additional skills in the supervision. So I think starting the treatment and not without supervision would be quite hard to do. The other point is that services differ a lot about what they expect of their therapist, uh, and and some services in some services you basically you have one session with a patient with PTSD, then the next with a depressed patient, and then the next one is an anxiety disorder. And you can't. It's very difficult to be like specialized in so many different disorders. They are quite different in their presentation, also in what the treatment looks like. So I think from a service perspective, it would be quite useful to really allow therapists to choose. I want to now specialize in PTSD. I mean, not as the only disorder, but as one of my main disorders, and that will make it quicker for them to gain the experience because they have see more patients at the same time, and also I think they get more out of it from seeing different patients, especially with the individual case formulation. You learn more quickly, and then also for retaining the workforce, which is another challenge that people move on to other jobs sometimes, and that's obviously from a service perspective quite difficult if you invested a lot in training, so I think the supervision and specialization, allowing specialization, and then not arbitrary time limits, I think would be from my perspective some of the obstacles we have seen.
Yeah, it sounds like, as with really any of the specific trauma-focused treatments, you need more than just a workshop to be able
Yeah,
to really get
yeah, yeah,
proficient in
yeah,
treatment. And then, yeah, seeing enough patients for to be really able to see a range of presentations and kind of really integrate that treatment into your
yeah.
practice.
Yeah, and I think it also helps, I think, given the therapist confidence, because
Yeah.
that's I think another thing we've seen sometimes, or sometimes therapists have still some concerns about doing trauma-focused work
Mm.
because they believe it might harm. They don't want to harm the patient, obviously, and they don't want to induce dissociation or flashbacks, and then being able to handle these difficulties in a session with the patient that will really help them feel more confident.
Yeah.
So.
Yeah, certainly that is a unique challenge in doing
Yeah, it is. I
PTSD
think that is
treatment.
not a specific one to yeah.
Yeah.
So I think that's common to all trauma-focused treatments.
hmm and have there been any changes to how this treatment is implemented over time? It's been around for many years at this point.
Yes. Yeah, we have learned a lot from the different patients we have seen from us, both in research studies and also in our clinical practice. And yeah, what are the main things we have changed? I think initially we were focusing a lot on imaginal exposure because that was the technique we learned from Edna 4, and it's obviously a very powerful technique. But the more we saw people with very long traumas or a high dissociation and so on, we also using narratives more than we used from the beginning. I think that's fair to say. And we have got, I think, yeah, we learned a lot more about which of the cognitive techniques work the best for which kind of appraisal. So, for instance, interventions for shame. We also emphasize the multisensory in the updating process. We were initially getting quite far with using verbal updates, so what they learned from the cognitive work, but we really emphasize trying to really use multi-sensory input to really make the meanings, the new meanings sink in. So that could be simple things like if somebody was trapped in the trauma, like moving around is a very good update for that, that you're not in the trauma anymore and you can move freely. Or if you had a very bad injury and maybe had problems with walking around, that's a very good update. But also other sensory information, such as smells that were not there at the time, can be very powerful, or taste, like somebody had a lot of blood in their mouth at the trauma, than having a sour sweet or something in your mouth with a different taste, is immediately brings home you survived this, and you're not in the trauma anymore. Or imagery. From the very beginning, our colleague Anne Hackman was an expert in imagery scripting, and she used it a lot from the beginning. But I think we, as a team overall, have more and more seen how powerful imagery scripting is. And even if people obviously know that it's an imagery exercise, it really makes the new meaning sink in very well. So we continue to learn.
Yeah, it sounds like many, many tweaks that have made it both more tolerable and also more powerful over
Yeah,
time.
yeah, yeah. I mean, we always got very good acceptability was very good from the beginning, because we got very low dropout rates in all our studies, and I think that has to do, or at least I tend to think it has to do with really focusing on the meanings rather than on the repetition of the trauma work. So learning from the cognitive work, and then really being quite efficient in putting into right spots in the memory. That uh, took yeah, that's much faster than doing repeated exposures over a long period of time. So
Yeah.
the acceptability was good from the beginning, I think, but as you say, what is the most powerful intervention for certain types of beliefs is a learning, was we had learning about that. Yeah.
Well, those are all of my questions. But is there anything else that you want to say, or anything you wish I had asked at this point?
I think I would like to mention that we've thought a lot about how we can disseminate the treatment to more people, and there's always the problem of therapist capacity. So we have developed an internet delivered version of the treatment, which consists of modules that we've written that the patient works through. It also has special pages for them to work on the hotspots and triggers. Um, and and we found that we can achieve the same efficacy when using this treatment with therapist support. I should say it's not it's still support by therapists who know the treatment well. So it's not just encouraging to work on the modules, but we could deliver the treatment in using half of the therapist, or less than half of the therapist time that it would usually take to treat the patient, and that is hopefully a contribution to making the treatment more accessible. We are currently rolling out this treatment in England, and it involves again training therapists to support the patients through this program. But there was one finding I wanted to mention from our previous studies, that shows that when we asked therapists about their experience with delivering the internet delivered treatment, they said that they actually learned so much from actually delivering the treatment this way. So there were some elements of the treatment that they really benefited from working together in this new format, because it deepened their understanding of the treatment. So it could also be possibly a teaching tool as an alternative to the workshops and supervision that we talked about. Supervision we'll also have to do, but it could be another component of making the treatment more accessible to more people.
Interesting. So both more accessible because you can kind of stretch therapist time, but also helpful to the therapist, it sounds like, in better
That
learning and
was the
treatment.
feedback, yeah. So that was really interesting for us to hear that the therapist found it really useful learning experience for them as well.
Okay, that's really interesting to hear. Thank you.
Yeah, just would like to encourage anybody who's interested to have a look at our website, explore that, and hopefully find something useful. I haven't mentioned that we had started a process of translating the subtitles of the videos in various languages. So, for instance, we're working with our Ukrainian colleagues who gave translated the subtitles. So it should be accessible to quite a wide range of therapists in different countries.
Oh, awesome. Yeah, and like I said, I've been on the website. It's really an amazing resource.
Mhm.
So we'll put that up at the end of the talk. But thank you so much for being here today and for the work that you've done.
Thank you for the opportunity to speak to you, and I thank you very much for your interest.